Imagine trying to do your job with a constant stream of vital data rushing directly at you. In a clinical environment, the sheer volume of information creates a constant pressure where a single missed detail has immediate consequences. Take a routine shift change. A physician, Dr. Vance, delivers a briefing at a dead sprint. Patient is post-op day 2, suspected biliary leak, elevated bilirubin. Order an MRCP, keep him NPO, monitor for pyrexia. When Nurse Simone tries to ask for a specific time, Vance tells her to just check the digital records and disappears. Overwhelmed by the data, Simone moves to her patient, Mr. Gerard. He is visibly anxious, explaining that he can't go home because his wife has limited mobility and he can't manage the stairs. Simone, distracted by her pager, interrupts him. She tells him a story about her own surgery and her dog, assuring him that being jumpy before discharge is normal. These failures in listening result in a loss of professional trust and a breakdown in patient safety. Because Dr. Vance didn't wait for a response, the MRCP could be delayed. Because Simone didn't hear Mr. Gerard's specific fear about his wife, he remains unprepared for discharge. You can fix these breakdowns before they happen. We are going to conduct a conversational rescue audit using a 3-step framework called Active Empathic Listening, or AEL. This graphic breaks down Dr. Vance's briefing to show exactly where the communication failed. The highlighted medical jargon creates a semantic barrier. Layering too many of these complex data points into a few seconds of audio creates an immediate information overload. When a speaker prioritizes conversational speed over the recipient's ability to comprehend the message, the listener's working memory reaches its limit. Information overload ensures that crucial details like the bilirubin check or the NPO order will be dropped. A different blockage occurred with the patient. Mr. Gerard's fear created a psychological barrier, and Simone reacted with a common mistake called the shift response. A shift response happens when a listener takes the speaker's topic and turns it back to their own experience. Sharing a personal anecdote about a dog might feel like a way to relate, but it breaks the empathetic connection because it forces the anxious patient to stop talking about their own fears and listen to yours. Identifying these blockages, the semantic barriers, the information overload, and the shift response, is the required first step. Once you spot them, you are ready to deploy the active empathic listening protocol. Step 1 in our framework is sensing. Sensing is the conscious effort to pick up on the relational content and emotional needs that the speaker is implying, rather than explicitly stating. You are listening for the tone, the body language, and the hesitation between the words. In our baseline scenario, Mr. Gerard's request for help with the stairs signals a deep anxiety about his lack of physical mobility at home. By failing to sense this, Simone misses the real source of his distress and offers empty reassurance instead of help. Without this sensing stage, professionals treat the spoken words instead of the underlying emotional state. You end up answering the wrong question. Step 2 of the framework is processing. As you see here, processing is the cognitive work required to retain raw data, track multiple points, and draw those data points together into a single organized working whole. Simone can use processing to neutralize Dr. Vance's information overload. She does this by filtering out the noise and immediately summarizing his actionable orders out loud, keeping the patient NPO and starting the lactated ringers. Processing also tells you what you are missing. By synthesizing the data in real time, Simone can ask a targeted clarifying question, such as confirming the exact time for the MRCP before Dr. Vance walks away. Processing converts passive audio reception into a clear set of informed, actionable steps. The third and final stage of the framework is responding. Responding requires using verbal and nonverbal cues, like eye contact, head nods, and paraphrasing, to prove you are entirely receptive to the speaker's ideas, rather than your own. Look at this split screen. On the left is Simone's failed shift response, centering her own story about her dog. On the right is a successful active empathic response, where she addresses the patient's actual concern by offering to arrange a home care assessment with a social worker. When a patient receives a response that directly addresses their specific concern, their physical anxiety drops, they relax, and relational trust is established. Responding is the observable proof to the speaker that you successfully completed the internal work of sensing and processing. To improve organizational outcomes, Professional empathy and social skills must be measured scientifically. You cannot manage what you do not measure accurately. Historically, institutions relied on psychometric tools like the Watson-Barker Listening Test, or WBLT. But relying on outdated metrics provides a false picture of staff competence. This chart shows the original 5-factor model of the Watson-Barker test. When researchers applied this test to multicultural populations, specifically Hispanic American post-secondary students, the data showed little association across the items. The model fractures completely, proving it lacks psychometric validity for a diverse population. A validated, modern alternative reorganizes the approach. This is the Active Empathic Listening Scale, or AELS, which clearly divides the measurement into 2 distinct categories: activity and empathy. Activity quantifies a professional's cognitive involvement, their ability to retain information and summarize points. Empathy measures their emotional alignment, their tendency to experience a congruent emotional response and read nonverbal cues. By utilizing validated metrics like the AELS, organizations can accurately evaluate and train communication competence across a diverse, modern workforce. Let's review the rescued scenario. Dr. Vance gives his briefing. Simone synthesizes the data and clarifies the MRCP timing before he leaves. Simone then speaks with Mr. Girard, senses his fear, avoids a shift response, and offers a concrete solution for his home care. The coordinated use of sensing, processing, and responding turned a fragmented briefing into a clear plan and provided Mr. Girard with the social support he needed to recover. Your next step is practical. Pick one specific conversation you have scheduled for tomorrow. Intentionally monitor your own reactions and stop yourself from using a shift response. Keep the center of gravity on the speaker. Communication is determined by how actively and empathetically you choose to